The slides are not up. Let me try this extempore. The objectives of my talk are essentially to talk about why do we need to treat atrial fibrillation in the first place? Is anticoagulation beneficial at all? Rate versus rhythm control, the eternal debate, and the fact that what are the new literatures to help us? Atrial fibrillation, when persistent and increasing in burden, confers a 1.47 increase in the risk of sudden cardiac arrest or of 1.32 in the risk of CVA, despite the use of anticoagulants. So to prevent a patient to be in persistent atrial fibrillation or with a higher burden of atrial fibrillation is the goal of managing atrial fibrillation. Higher burden of atrial fibrillation also results in more hospital admissions for heart failure. It has been proven that atrial fibrillation also causes a poor compliance and quality of life in patients who have higher burden of the disease. So, preventing high burden of disease seems to be a critical component to ensure that patients do not have high amount of mortality, do not have higher strokes, and lead a good quality of life. Towards these are our mechanisms for management of atrial fibrillation, namely anticoagulation, lifestyle measures, rate control of the ventricular rate, as well as rhythm control. Now, coming to the concept of anticoagulation, the CHADS-S2 score remains the backbone for management of stroke prevention in atrial fibrillation. The current drugs for management of atrial fibrillation prevention for stroke management include the NOACs, which is the class 1 indication, and the choice of drug management if we are trying to prevent strokes. Mitral stenosis and mechanical valves are the two contraindications for the use of NOACs. As far as the use of warfarin is concerned, if patient is unreliable in the use of anticoagulation, warfarin is your drug of choice. If the patient is using ritonavir or ketoconazole, warfarin is your drug of choice. Do not give NOACs along with any kind of CCBs, especially when rate control is considered. It increases the bleeding risks in these patients. Dose-dependent modification for only those patients who are evaluated under trials for purposes of dose modification. Otherwise, the doses of NOACs are not protective against stroke. For most of the trials, it is the higher doses that are indicated. Randomly decreasing these doses for an Indian population is a recipe for disaster. Going on from there to what I like to call the lifestyle management. Atrial fibrillation is a disease that comes because of the way we have lived our life. It's a sum total of all the choices we've made of what we've done throughout. So lifestyle management remains the keystone for the management of atrial fibrillation. The head-to-toes approach, wherein we are looking at obstructive sleep apnea management, obesity management, management of exercise, remain the cornerstone for the lifestyle prevention for atrial fibrillation. Then we come to the eternal debate between rate control and rhythm control. The AFFIRM trial threw a spanner in the works for all rhythm control for about 20 years. But now that we have data on 20-year follow-ups of AFFIRM, we are realizing that patients who are left with improperly treated atrial fibrillation without rhythm control had higher incidence of heart failure as compared to patients who did not have the same. It doesn't want to move. So let me just continue. So the AFFIRM trial actually showed that patients who had rate control for atrial fibrillation had higher incidences of heart failure as compared to those who were attained rhythm control. Additionally, heart failure also results. So stuff that we've already talked about, so I'm just skipping through. I'm going to start from here. So what are we talking about when we are saying rhythm control is cardioversion? You need to cardiovert patients. There is no second thought about it, even if the patient is asymptomatic, because the ESC guidelines tell us that these patients may actually not feel their symptoms. And for all of us who are sitting here who are worried about cardioversion, it's not really very worrisome, as this cohort shows us over close to 9,000 patients. The benefit for thromboembolism actually decreases over time, as you can see between 2012 and 2018. Going on from there, so what are the factors that favor rhythm control? Let me just bring you down to the second last of those. More LV dysfunction, you want to do rhythm control. More AV regurgitation, you want to do rhythm control. So that is the subset in which you are looking at rhythm control in these patients, because atrial fibrillation definitely causes LA myopathy. LA myopathy predicts CVA and emboli independent of AF burden also. So it's like a self-fulfilling prophecy where more atrial fibrillation causes myopathy and myopathy causes more stroke. So when you look at the limitations of the AFFIRM trial, we already discussed that there was poorer management of heart failure in these patients resulting to these problems. So what is the aspect of which, how do we do this rhythm control? So if you have an access to somebody who does a catheter ablation, it's by and far very clear that catheter ablation is superior to medications for rhythm control. The Cabana subset, the East AF subset, both of them showed that catheter ablation was superior. But what the East AF net also showed us, which is the AFFIRM trial of our generation, is that if you did rhythm control, even with medications, within 1 year of the diagnosis of atrial fibrillation, you had benefit. You had mortality benefit, you had recurrent hospitalization benefit, independent of whether the patient was symptomatic or asymptomatic with atrial fibrillation. The same was documented with the first episodes of atrial fibrillation when they were persistent atrial fibrillation with the cryoablation trials. Even in patients with symptomatic paroxysmal atrial fibrillation, the ablation actually showed benefit. It also ended up in showing prevention of progression of atrial fibrillation. Remember what we said. Higher the burden of atrial fibrillation, more the persistent atrial fibrillation, more the chances that you had strokes. So if you had something to prevent progression of atrial fibrillation, this would what it would be. This trial actually probably stamps the reason why we should do AF ablation in patients with heart failure. The Castle HTX trial took patients on the transplant list with atrial fibrillation, ablated them, and about 40% of them went off the transplant list. So there is definite burden even in late stages for maintaining rhythm control in these patients. We did discuss very briefly about HFpEF and HFrEF in our previous heart failure section. Ablation, this randomized trial for ablation in HFpEF also showed that it actually decreased hospitalization, and there give a hypothesis generating thought that it may prevent progression of HFpEF in these patients. The registries actually showed close to 26,000 patients to show reduction in the composite of all-cause death, stroke, and major bleeding. It also showed us that if you treat 5 patients with ablation, instead of an AAD, you can prevent 1 recurrence of atrial fibrillation. That data is already present, and early initiation of rhythm control was associated with improved effectiveness outcomes in patients who have been diagnosed with atrial fibrillation in the last 1 year. Catheter ablation, as I mentioned, also decreases the progression of atrial fibrillation. This is more prominent with respect to RF as compared to cryo. So all of those who think that cryo is better than RF, there is not really any data on that. It is statistically non-inferior, and if we consider the endpoint of progression, cryo is inferior to radiofrequency ablation. If you look at persistent atrial fibrillation, there is benefit even when the AF history is more than 4 years, although it is at the cost of increased procedures. That remains your cost that you give. AF ablation done with guidelines, most often by contact force generated radiofrequency ablation to achieve pulmonary vein isolation, and that is the only thing that works, with a low in-hospital complication rate, does show significant benefit in preventing recurrence of atrial fibrillation and thereby preventing mortality in patients with heart failure. I keep saying about heart failure because that is the critical part here. Last but not the least, let's look at what happens when you have persistent atrial fibrillation and you have failed ablation. Ablate the AV node, put a CRT in, there is still a 40% benefit mortality in these patients. So again, smaller LA, more LV dysfunction, more valve regurgitation, you are basically going for rhythm control. Most importantly, this is now reflected in the guidelines where it's a class 1 indication for AF ablation in decreased ejection fraction, and in HFpEF, it's a class 2A indication. AV nodal ablation and pacing for those difficult to treat patients is critical. What AF needs is not a sole management. In fact, it is the AF clinic that you need to generate, where you're looking at motivating the people, looking at the head to toes that you can see, the weight loss targets, the management for sleep apnea, and then finally evaluating what is the correct time for intervention in the form of ablation. Of course, just like everybody else, there is potential criticism that you can have. There are potential unknown ideas what we should do, especially regarding the substrate in HFpEF, but these are for later. In summary, therefore, increased AF burden independently increases the risk of stroke despite the use of NOACs. OACs are critical in preventing CVA. NOACs are drugs of choice. Rhythm control has mortality benefit in heart failure. It prevents progression to persistent atrial fibrillation. Ablation is better than drugs, that much is clear. Rate control has restricted use, but an important use. Cardioversion is safe and definitely underutilized. And finally, the acronym for head to toes for lifestyle management of atrial fibrillation is critical. Thank you for your patient hearing.
Wonderful, sir. Wonderful.